What would you say the next big thing is when it comes to improving diagnosis? So 2 years from now, we had another panel. What kind of topics do you think we would be talking about?
Well, this is Mark. I would love to come back in a couple years and hear that there are patient-based organizations that have really taken this on and are thinking about how patients could be more involved, and Sue will hopefully amplify on that. I hope there's healthcare organizations that have started to try some of the interventions that have been proposed and are happy with how they're working and publishing those results so that we can all learn from that kind of experience. In other words, we'd like to see action. And now it's early in the game, but this is the time when we need to start seeing some action towards trying out these interventions.
I agree with Mark's vision. I do think that he's spot on when it's about trying out these interventions. I think we have spent a tremendous amount of very valuable time researching diagnosis. Those of us that are passionate about it are a small but powerful group that's growing and raising awareness. The coalition is a great example of expanding it. But I think we're at a pivotal period in time where this is a personal comment, but I would love to stop debating whether we have the right definition or the right way to capture it or the perfect best practice to solve it. I think there are many, many pockets driven by patients, driven by providers, driven by the health insurers, driven by so many other organizations that are rising up with a passion and an interest in it. And we've got ideas. And I just want to see some of these starting to move forward, be implemented, to be embraced. There is no one solution, as we said earlier. This is a collective effort across numerous avenues and parts of our healthcare system. And I would just love to see people embracing patient safety, leaders embracing diagnosis as a key target, as a priority on their patient safety agendas. I want to see it on the dashboard. I want to see it right beside falls and medication errors in hospitals and ambulatory centers. I want it to become a key focus for solution-focused action, not just research and discussion.
I would agree with all of that. I think the other thing is that I would think and hope and expect that this concept and this work gets integrated into what I'm going to call the evolution of public health in the country. Because part of what we see is our community collaborations and the work that's happening around the RWJ stuff, around the culture of health, and understanding the social determinants of health, and breaking away from our silos, that as we develop a better collective wisdom around what health means, that I'll say using our voice and appreciating things like the relevance and the importance of improving diagnosis can get integrated into those larger spheres as well. I think
love it.
As owners of this in the healthcare delivery space, we have to acknowledge that healthcare delivery in conjunction with our public health partners is not going to look 2 years from now like it does from today. We've been alluding to it. The CVSs, the Amazons. So getting this into the definition of health, or a key component of this, I think would be useful and possible. And through the campaign that CITM's going to do, and through raising the awareness, then we begin to see the cohesiveness of this as one more thread to health. It's not a separate thing. It's an integral piece.
So this is Mike. I think I echo my colleagues' comments previously, and maybe I'm sounding like a broken record here. And you know, I'm hoping that as we look forward into the future, or we look backwards, I guess, from the future, we see the much more open conversation across all levels of healthcare around this issue and with patients, and that can we maybe decriminalize? That may not be the right word, but can we decriminalize errors so that we're actually they're seen as learning experiences, just like when a child falls, they trip something, we shouldn't be yelling at them because they, tripped and fell. We should try to teach them how to, walk or run better or whatever the motor skill may be. I think this is a motor skill. This is a cognitive skill, and in some way move away from the punitive culture, the punitive legal system, and use every event that occurs. And we should have a system to find out where in the system or in the cognitive process the error occurred, and that we all should be able to learn from it, and that there's free learning also across organizations, and that we don't have to build huge impermeable walls in order to protect ourselves from liability, but rather that can we live in a world where if I see an error or if I see an issue with a medical device, that I can share that across my peers so that the next patient isn't harmed by that same error, by that same device or that same procedure, without worrying about the liability issues.
Here on that.
And Dana, I'm sorry to put you on the spot, but I'm going to anyway. Since you started off your career in the clinical realm and now you're on the claim side of it, so you've had a foot in each world, is there anything that you wish that your fellow clinicians knew about building on Mike's point?
Yeah, and I think I alluded to it a little bit earlier. I mean, certainly I've been out of the clinical realm for plus years, probably 25 or more. From being a direct frontline provider, I continue to do assessments in the clinical realm all the time, so I live in those environments and talk to the providers. I don't know if there's any way we could have known better then, but I do wish we felt safer earlier, and I think we are starting to feel safer in having conversations about being human and making error and being able to open up to our peers and to our leaders to allow ourselves to sort of unwind the mystery of how mistakes and errors happen so that we can better understand how to build systems that are safer. I wish I had known or had a better connection when I was a frontline clinician to risk and patient safety. In the younger years when I was there, risk was a sequestered team that lived in the basement behind a heavily locked door. And when a risk manager walked on your unit, you ran. We were that disconnected from the importance of talking about vulnerability. And quite honestly, in the earlier days, I think risk really was about risk mitigation and reduction of the subsequent harms from a patient perspective, but quite honestly, more from a business perspective. I wish we had known the relationship between our actions and subsequent errors. The feedback loops were not strong then and have grown much better now. But that said, I think that not innocence, but that void, that vacuum, that I still think there are clinicians living in that vacuum today, that they still fear risk, they still fear patient safety. We get quality, we're doing good in that, but we don't understand the value. And we don't know how to participate. So I wish somebody had told me how to fill out an adverse event report, that it was safe to do it, that data mattered, and more importantly, I wish they fed it back to me. We do not provide enough feedback to our frontline clinicians to get them engaged and invested. You do, even now, if you do an adverse event report, I hear from so many people when I do risk assessments that it goes into a big black hole, and they never know if anybody got it, cared about it, or did anything about it. So there needs to be a feedback loop between those of us that are aggressively managing, measuring, and passionate about changing things with the very people that we depend on to provide us insights to what's going on, and then to champion our messages once we get them right. So I guess I'll stop there and say, yeah, I've learned a whole lot for being on this side of the data world, and wish we had a better connection between, we don't need new data, we just need the data that we have available to us to reach the people who can begin to embrace it and be enlightened by it.